My name is Jennifer Mascarin. I am a Doctor of Nursing Practice student with a focus on pediatric acute care at the University of South Alabama. I will be discussing my quality improvement project titled Implementing a Pediatric Asthma Clinical Pathway in the Primary Care Setting. Asthma is a chronic inflammatory disorder of the airways that causes obstruction of airflow. During an acute exacerbation, the bronchial mucosa is edematous, and there is an increase in mucus plugging causing airway obstruction with resultant bronchospasm. If airway obstruction progresses, it can lead to ventilation-perfusion mismatch and subsequently hypoxemia. Severe airway obstruction can be fatal. In the United States, approximately 8.6% of children under 18 years of age are diagnosed with asthma. Each year, asthma accounts for a loss of 10 million missed school days for children and adolescents aged 5 years to 17 years and is the most common chronic condition requiring hospitalization. For many children, pediatricians provide asthma management and are subsequently the first line in prevention of costly hospitalizations and trips to the emergency room. Early treatment is the most helpful in the management of an acute exacerbation. Reversal of airway obstruction is the primary goal in the treatment of an acute asthma exacerbation. Hypoxemia may also occur during an asthma exacerbation and can be resolved with the use of oxygen. Reversal of airway obstruction is accomplished using short-acting beta-2 agonists. Prompt use of corticosteroids is imperative in the treatment for an asthma exacerbation. Corticosteroids help to treat the inflammatory process that occurs during an exacerbation. Studies show that adding multiple doses of an inhaled anticholinergic, the short-acting beta-2 agonist, can improve lung function and reduce hospitalizations in school-aged children. Clinical pathways have proven beneficial in the ED and in the inpatient setting in the management of an acute asthma exacerbation. Clinical pathways have decreased the number of admissions from an ED to inpatient unit, reduced costs associated with treatment, as well as reduced length of stay in the hospital. There is currently very little use of a clinical pathway for asthma management in the primary care setting. The purpose of this quality improvement project is to bridge the gap between the recommended guidelines of the National Asthma Education and Prevention Program and asthma management completed at the Pediatrician's Office, Medical Specialists, Inc. A pediatric asthma clinical pathway was developed for use in the primary care setting using the guidelines from NAEPP and additional evidence-based practices. The goal of the pediatric asthma clinical pathway was to more promptly recognize an asthma exacerbation, subsequently allowing treatment to be initiated quicker, reduce the need for hospitalization, and improve patient outcomes. The following PICO question was formulated to guide the project. Does an asthma clinical pathway help to recognize and begin treatment more promptly, improve patient outcomes, reduce ED visits and hospitalizations, and improve quality of life for children treated by their pediatrician for an acute asthma exacerbation in comparison to children who are not treated based on a clinical asthma pathway? The Quality Improvement Project was implemented at a rural pediatric primary care office, Medical Specialists, Inc., in Waynesboro, Georgia. An initial chart review was conducted over a 6-week period during the spring of 2016. 27 patients presented to Medical Specialists, Inc. with wheezing or shortness of breath. Of these patients, only 44.4% received an albuterol nebulizer treatment in the office, and only 0.07% received corticosteroids in the office. One patient was placed on oxygen and an ambulance was called to transport the patient to the ED. Results from the 2016 chart review demonstrated that NAEPP and evidence-based practice guidelines on asthma management were not consistently followed at Medical Specialists, Inc. An evidence-based asthma clinical pathway was developed by a pediatric acute care nurse practitioner. Healthcare providers at Medical Specialists, Inc. including a pediatrician and nurses, were educated on the asthma clinical pathway and pediatric asthma score using an informal lecture format. Binders with the pediatric asthma score and 3 different asthma clinical pathways were supplied for each healthcare provider. The clinical pathway was implemented over a 6-week period during spring of 2017. The healthcare providers treated patients who presented with wheezing based on the clinical pathway. A retrospective chart review was conducted after this time period. Children over 12 months of age who presented to the clinic with wheezing were included in the study. Children less than 12 months of age, children with a history of congenital heart disease, children with a history of chronic lung disease, and children with unilateral wheezing suggestive of a foreign body were excluded from the study. 17 patients were included in the study and 2 patients were excluded from the study. The use of this algorithm helped healthcare providers determine if patients were to be included in the quality improvement project or must be excluded. It was also used to initiate the asthma clinical pathways. The pediatric asthma score was used to determine the severity level of the asthma exacerbation. Healthcare providers assigned scores based on the patient's vital signs and physical assessment, and the total cumulative score was used to determine the severity level. This chart provided an overview of normal heart rate and respiratory rate for children of certain ages. It assisted healthcare providers with assigning values to the pediatric asthma score. This algorithm was used for patients who were suffering a mild asthma exacerbation. It included treatment interventions, reassessment, and further considerations. The moderate asthma pathway was used for patients who had a pediatric asthma score of 1 to 3. It provided additional interventions to consider based on patient severity and progress on the pathway. The severe pathway was used for patients who received a pediatric score of 4 to 6. The pathway provided recommendations for treatment as well as disposition upon discharge from the pediatric clinic. During check-in, patients with wheezing or shortness of breath were triaged and placed on the pediatric asthma clinical pathway. A retrospective chart review was completed and the results were maintained on a database. The database was used to determine the age of the patient, if the patient was seen within 30 minutes of arrival to the clinic, if treatments were initiated within 30 minutes of arrival to the clinic, if the patient received an albuterol treatment, if the patient received a corticosteroid, if the patient received an Atrovent treatment, whether or not the pediatric asthma clinical pathway was correctly followed, the disposition of the patient, and if radiographs were obtained. Of note, during the retrospective chart review, it was noted many patients were discharged home with a prescription for an antibiotic. Therefore, the chart review was adjusted to include patients who received antibiotics in the physician's office or who were discharged home with a prescription for an antibiotic. Data analysis was undertaken using IBM SPSS Statistics 22.0. During the spring of 2017, 17 patients who presented to Medical Specialists Inc. were included in the Quality Improvement Project. 2 patients were excluded from the project due to age. Of the 17 patients, 64.7% were male and 35.3% were female. The mean age of patients was 6.26 years of age, and the median age of patients was 5 years. The mean pediatric asthma score was 0.7059 on initial presentation to the clinic. This number signifies the majority of the patients were only suffering from a mild acute asthma exacerbation requiring a treatment intervention with a bronchodilator. The mean pediatric asthma score on discharge was 0.2353. The decrease in mean pediatric asthma score from initial presentation to discharge demonstrates the treatment interventions on the pathway were successful in reducing the severity of the symptoms. The highest pediatric asthma score was 4 on initial assessment and 4 on discharge or transfer from the pediatrician's office. The pediatric asthma score of 4 indicated the patient was having a significant acute asthma exacerbation requiring prompt intervention. The high pediatric asthma score alerted healthcare providers to initiate the interventions in a timely manner and to facilitate transfer to a facility that could provide further interventions if the patient's condition deteriorated. Vital signs were obtained on 100% of the patients within 30 minutes of presentation to the pediatrician's office, allowing patients to be assessed by a healthcare provider promptly and to initiate the clinical pathway. Albuterol nebulizer treatments were also given to patients within 30 minutes 100% of the time. Of the patients who received one nebulizer treatment, all had significant reduction or complete resolution of wheezing. Only one patient received multiple nebulizer treatments. Only 35.3% of patients were given a corticosteroid in the pediatrician's office, while 88.2% of patients were discharged home with a corticosteroid prescription. 5.9% of patients received an antibiotic in the pediatrician's office, whereas 64.7% of patients were discharged home with a prescription for an antibiotic. Only 2 patients had a possible indication for an antibiotic. One patient had coarse breath sounds with slight wheezing, and the other patient had a fever in addition to wheezing. In both patients, there were concerns for a bacterial infection in addition to wheezing. A chest radiograph was obtained in 17.6% of patients. One patient was placed on oxygen in the pediatrician's office and was subsequently transferred to an emergency department due to the acuity level of the patient. None of the patients received an anticholinergic nebulizer treatment in the pediatrician's office. Based on patient assessments, the pediatric asthma score, and pediatric asthma clinical pathway, the clinical pathway was followed in 70.6% of patients and was not followed in 29.4% of patients treated at Medical Specialists, Inc. None of the patients treated at Medical Specialists, Inc. had a relapse or bounce back of their asthma exacerbation. The pediatric asthma clinical pathway improved use of albuterol nebulizer treatments and corticosteroid use in pediatric patients suffering from an acute asthma exacerbation during the spring of 2017. The clinical pathway did not improve the use of anticholinergic nebulizer treatments, which is also an evidence-based practice and has been shown to improve patient outcomes. In this small retrospective study of children with an acute asthma exacerbation that presented to their pediatrician at Medical Specialists, Inc., the use of pediatric asthma clinical pathway enables healthcare providers to recognize and initiate timely treatment. An asthma clinical pathway prevents unnecessary hospitalizations, treatments, and ancillary studies. It also reduces bounce-back pediatrician or emergency room visits. None of the patients who were treated based on the clinical pathway came back to the clinic for continued and/or worsening symptoms within a 2-week period after the initial visit. Additionally, there was no documentation that any of these patients required subsequent treatment from an emergency department. 64.7% of children were discharged home with antibiotics. Documentation from Medical Specialists, Inc. did not demonstrate a strong indication for antibiotic use in the majority of the patients. At least 85% of asthma exacerbations are induced by a virus. Adjusting the asthma clinical pathway to include indications for use of antibiotics would benefit providers and their patients, reducing unnecessary use of antibiotics, which will play a role in reducing antimicrobial resistant bacteria. Indications for antibiotic use would include suspected bacterial pneumonia and acute sinusitis. Additionally, including recommendations for chest radiography on the asthma clinical pathway will help limit exposure to radiation and reduce unnecessary medical expenses. Indications for a chest X-ray include suspicion of bacterial pneumonia, presence of a foreign body, patients that fail to improve with maximized conventional treatment and complications such as pneumothorax. There are limitations in this quality improvement project. This is a single-center study that only included a small amount of participants. If the patient charts were in an electronic medical record rather than paper charting, alerts for treatment interventions could be included in the program, as well as triggers for patient reassessment based on clinical asthma score. There was very little research and data on the use of a pediatric asthma score and pediatric asthma clinical pathway in the primary care setting. The pediatric asthma score and pediatric asthma clinical pathway was not internally validated prior to the implementation of the quality improvement project. The following are references used during the quality improvement project. Thank you for taking time to listen about the quality improvement project titled Implementing a Pediatric Asthma Clinical Pathway in the Primary Care Setting.